Hey, we're ready to continue with our program. So it's my great pleasure to introduce you our keynote speaker for this afternoon, Dr. John Stewart. Dr. Stewart is the founding director of the Louisiana State University LCMC Health Science Cancer Center. He also holds the rank now professor of surgery at the Louisiana State University Health Science Center in New Orleans. Overall, he is responsible for setting the vision for really propelling LSU into an NCI designation. And you heard Dr. Kerry Robinson from Board of Regents today, the importance and the effort, which is a statewide effort, to actually get an NCI designation for studying with leadership at LSU. So Dr. Stewart received his medical degree from Howard University. He completed a residency at the Vanderbilt University Medical Center, and he held a number of fellowships, including surgical oncology, immunology, molecular oncology at the National Cancer Institute. He, as you can read in his profile, is an established leader for education, for scientific research, and specifically to cancer. And even more importantly, for all of us, is the being a great advocate for promoting biomedical research and health-related initiatives to underreserved populations. So he's very well published, holds a number of patents, and dear to my heart, his practically effort is on oncolytic immunoviral therapy. And I actually look forward to collaborating with him in his current position right now. So without further ado, John, it's all yours.
I'd like to first thank you for that warm introduction and thank you for welcoming me back home. So I have a couple of disclosures. Disclosure number one, I am from Shreveport. Yes, that is in Louisiana still. Second disclosure, it's still kind of weird for me to say I'm driving up to Baton Rouge. So I'm going to take a few minutes to talk about the development of oncolytic viral therapy for the treatment of cancers. And we'll focus primarily on colorectal cancer, but we'll also give a little bit of a background on melanoma. So our three objectives are to review an oncolytic viral therapy, talk about the origins and the history, because I find that to be extraordinarily fascinating as it informs us about where we can move in the future. And then we'll discuss a couple of pivotal trials in oncolytic viral therapy and then detail the emerging oncolytic viral opportunities. So let's first talk about the origins of oncolytic viral therapy. So when people ask me in the grocery store, hey, what do you do? All right, well, I'm a cancer center director. I am a translational scientist. I do clinical trials, but I also have a laboratory that focuses on oncolytic viruses. So I get these looks, like, what exactly is an oncolytic virus? And I say, well, you know, I work with vesicular stomatitis virus, and then I work with herpes virus. And it's that last one that gets them, right? They just pause because it is hard for them to think that cancer could be potentially cured by a virus. And in fact, when we first began this journey, we'll notice that it was not intentional. It was not intentional. And in 1903, we had an incidental discovery by Dr. George Dock, who was at the University of Michigan, that had a woman who had what appeared to be an influenza infection while she had leukemia. And she started to feel much better. So shown here is Dr. Dock and his group. He was the head of the Department of Medicine at the University of Michigan. So here's the report of this woman's illness that was reported in the American Journal of Medical Sciences in 1904, although the case happened in 1903. So just kind of a summary of this is that this was a woman who was a housewife, I believe she was 32 years of age at the time, who had acute leukemia. Now, acute leukemia at that time was typically treated with arsenic, okay? Arsenic. So what we have here is that on her initial physical examination, she had a white blood cell count of about 90 and 90,000, which is extraordinarily high. And what we see here is that she had what's called hepatosplenomegaly. Okay, so the students, and if the students know what hepatosplenomegaly is, all right. So your liver and spleen were enlarged. Usually you can feel your liver right around here. On this first exam, they felt her liver all the way down here below the costal margins. The spleen, which usually is palpable right around here, was all the way out here, okay? So she had physical examinations that were pretty significant. She had laboratory values that were pretty significant. And then she went home and got what was presumed to be the flu. runny nose, scratchy throat, felt terrible, got back to the doctor's office, Dr. Doc's office in particular, and noted that she had dramatic resolution of her physical examination findings and a significant improvement in her laboratory findings. So during that first exam, it was noted that her spleen, or that her liver was still pretty large. However, her spleen began to shrink, and so it was palpable all the way only to here. On a subsequent exam, we noted that her liver margin was now out to here, so again, decreased in size, and her spleen continued to be stable. And her laboratory values continued to improve. And so this continued until about month 6, when she ultimately died of her disease. And so George Doc was an extraordinary clinician. He was an extraordinary historian. And so when he put the two facts together, he said that such a change is more marked than one typically sees in leukemia under treatment. This forces one to try to learn something from it, not only as regards to pathology, but even more imperatively, something of therapeutic value. This, I would submit, was the beginning of the field of oncolytic viral therapies. Now, we've had a number of trials since then, and this is a timeline that I believe lays things out pretty well with respect to all of the activity that has occurred with oncolytic viruses over the years. So for instance, in 1912, people were attempting to use rabies virus for cervical cancer. As expected, it didn't really work out that well. But again, it was an attempt to treat cervical cancer with a new approach. Fast forward to 1949, there was actually a couple of responses of patients with non-Hodgkin's lymphoma who were treated with hepatitis B virus. There was a bevy of activity in the 1950s, including an Egypt 101 virus trial and adenovirus for cervical cancer. And I just want to pause here for a second, because that trial was actually conducted at the National Cancer Institute. And it was noted that they had liquefaction of the cervical tumors when they were injected with adenovirus. Unfortunately, the tumors would ultimately continue to grow and result in the death of the women who were treated. But again, very preliminary support for the use of oncolytic viral therapy. Now, let's talk about the viruses that were used in the 50s, the 60s, and the 70s, okay? Does anybody understand the difference between a wild-type virus and a mutated virus? Okay. We did not have the molecular techniques up until the 1990s to mutate these viruses. And so people were exposed with pretty pathogenic agents to treat cancer. However, and what we'll show here is that actually some of these were okay. So I'm going to show you some data from Asada et al. In which we had the treatment of dermal metastases from breast cancer. So shown here on the left, we've got dermal metastases right here, right here, right here. Got some redness here within the skin lymphatics. This patient was treated with 2 courses of mumps virus, and what you'll see is that all of that resolved. Again, this result was relatively short-lived, approximately 6 months, and she went on to have progression of disease. But again, continued remarkable response to oncolytic viral therapy. The field lay dormant for about 25 years. However, we began to really understand how molecular therapy can allow us, or molecular techniques can allow us to mutate these viruses and move them to the clinic. So how many of you have ever heard of Onyx 15 oncolytic virus? Okay, it was adenovirus, okay? Now, many people think that Onyx 15 did not really work that well, okay? Just because it never really exploded, right? It never really hit the market. This is an unfortunate example of what happens when small biotech companies get acquired by larger companies, because larger companies evaluate their portfolios. They try to understand what's going to be profitable for them and what's not going to be profitable. And Onyx did not make the cut. Now, let's think about this for a little bit. I gave a very similar talk with actually the same timeline about, so see, this was pre-pandemic, so probably 2018 or so. And I had 2 surgeons walk up to me who participated in the Onyx 15 trial. And they said, we had patients who did really well with this therapy, and we never understood why it did not move forward until the history was relayed to them. Okay. Until the history was relayed to them. So again, Onyx, just an unfortunate collateral damage due to acquisition in the market. Now, let's move forward to 2003. There is this virus called BioVex. Okay, BioVex, modified herpes trial with GM-CSF, pretty attractive, was started by a company, BioVex, and was moved to early phase clinical trials. Okay. So in the interim, we had our drug move from BioVex. It was renamed to TVEC, and now it's Imlogic. And TVEC was the first approved oncolytic virus in the United States, and that was approved in 2015. And it seems like it was just yesterday when it hit the market, because we were all excited, because as you know, advanced melanoma at that time had very limited therapeutic options. So what's the rationale for oncolytic viruses? I mean, so we saw something in the clinic. We've had a few clinical trials. Why continue this? Why continue this course of endeavor to help try to improve cancer? So Justin, I'm going to geek out here for a minute. Well, I'm a science conference, so it's cool. All right, so during normal cellular homeostasis, proliferative signaling pathways and antiviral signaling pathways are at equilibrium. However, during molecular carcinogenesis, the proliferative signaling pathways outweigh the antiviral signaling pathways. And so you have increased representation of antiviral signaling, increased representation of proliferative signaling, such as epithelial growth factor, TGF-alpha, and platelet-derived growth factor. And you have a downregulation of things like interferon signaling, TNF, and interferon-stimulated genes. So this actually gives cancer cells a growth advantage at the cost of antiviral signaling. So why is this relevant? Why does this make sense? Why does this help viruses become more selective for cancer cells? So during viral infection of normal cells, you have viral particles that are in the normal cells, as indicated by the red figures. You have an increase in interferon signaling, and then you have antiviral signaling in the surrounding cells. And so in the index cells, the virus dies. It dies, it goes away. We're all good. However, tumor cells have defective antiviral signaling. And so upon infection, you have propagation of the virus throughout the adjacent cells, and they die. So what happens at the tumor microimmune environment? Okay, and so at the top is a cancer cell, and it has tumor-associated antigens. If you treat with an oncolytic virus, we know that viruses are very, very, very immunogenic, and so those viral proteins not only tag the outside of the cancer cells, but you also have a cytopathic effect, and that cytopathic effect subsequently primes the surrounding immune system. And with this immune priming, you have both pro-cancer immune responses and anti-cancer immune responses. So chief among those pro-tumor immune responses are myeloid-derived suppressor cells, tumor-associated macrophages, and T regulatory cells. Anti-cancer immune response includes TAMs, B1 cells, natural killer cells, cytotoxic T lymphocytes, and T helper cells. And so there are a number of oncolytic viruses that have been investigated. We talked about herpes virus. Again, I've worked with vesicular stomatitis virus for the past 15 years. Polio virus is in vogue at Duke, adenovirus, and measles virus. So let's talk about the herpes virus that's actually in the clinic. Previously known as TVEC, now known as Imlogic. So this is the genome of the Imlogic virus, and just suffice it to say that there have been substitutions in which the GM-CSF cassette has been placed at the delta 34.5 position. That will allow the virus to not only have an oncolytic effect, but also have an immune stimulatory effect. And so the pivotal trial that led to TVEC being approved for therapy in the United States was called the Optum trial. So this is a trial in which patients had, it's a phase 3 trial, in which patients with unresectable malignant melanoma, i.e. stage 3B and 4, were randomized in a 2-to-1 fashion. So for every 2 patients that got Imlogic, 1 patient got GM-CSF. So why did they use GM-CSF as the quote unquote placebo? Frankly, nobody wanted to give their patients saline, right? I mean, that's just unethical. And so GM-CSF has actually been shown to be immunostimulatory and subsequently able to have some level of immune response in these patients. So what do we find in that Optum trial, Optum 3 trial? So number one, we found that we had a 16.3 response rate compared to a 2.1% response rate in patients treated with GM-CSF. So I know a lot of that are just words to you, but I like to show pictures, okay? So this is an example of a clinical response that we had to a patient who was treated with Imlogic, okay? This is a patient with what we call a complete response, i.e. all tumors went away. So here we are in cycle 1, okay? And that's like the first dose of immunotherapy in which we would inject up to 4 × 10 to the 4th viral particles in these tumors, okay? And then after 13 treatments, we had almost near resolution of the tumors. It's a patient with what we call a partial response, i.e. greater than 50% of the tumor went away. This is what we had pre-treatment. And I'll draw your attention to these skin grafts because that's really what we have to do in patients who have widespread melanoma. And then after 10 cycles, you only see tumor at the periphery of the skin grafts, which could be surgically removed. So I was called to a meeting in New York. I believe it was probably around 2015 or so when Imlogic was first approved. And understanding kind of the clinical landscape of the treatment of malignant melanoma, we were brought as an advisory board to really talk about how we move TVEC, now Imlogic, into the market. And so at the conclusion of the meeting, I talked to some of the medical reps and I said, listen, your market for melanoma is about to get really small because we knew immune checkpoint inhibitors, drugs that could take the brakes out of the immune system, were also coming to market. And so I have an interest in peritoneal carcinomatosis. Okay? Peritoneal carcinomatosis, and is a disease in which you have a tumor that starts somewhere in the abdomen, and then it spreads not only to the omentum, but other organs in the abdomen. And so let me orient you here. This is a patient's head. This is the patient's foot. This is the patient's right side, left side. These are my hands, okay? So when I first started, we would take a patient to the operating room. We'd resect a bunch of tumor. We'd run warm chemotherapy through the abdomen. And at the end of, depending upon how much tumor we had, 10 hours, 11 hours, 12 hours, we'd close the patient up and then we'd go home. Now I kind of fell into this practice. I mean, I had this practice well made or well established. And in fact, at Wake Forest, which is where I was for my first job, we would do 3 of these big operations a week. And so my senior partner would operate on Monday. I would do a case on Tuesday, and my other senior partner would do a case on Thursday. That made us the highest volume center in the United States. My only beef with this, though, is that we were running warm chemotherapy through someone's abdomen after a huge operation for 90 minutes. Make sense? Not so much, right? Not so much. To me, it felt like, and as I kind of thought more about this and the biology about this, is that it felt like it was just a really expensive warm bath after a big surgical operation. And so the biggest benefit was with the surgery and not necessarily with the chemotherapy that we were delivering. So what's the natural history of patients who have peritoneal surface malignancies or carcinomatosis? So EVOCATE-1 trial actually looked at this at about 2000, and they looked at 370 patients who had carcinomatosis from gastrointestinal sources, and they found that the median survival was 6 months, or the mean survival was 6 months. The longest survival was 4 years. 1 patient out of 378 or 370 patients. The operative mortality, i.e. how many people died 30 days, within 30 days of having the operation, was about 1 in 5. And the 5-year survival, 0. Okay. This is considered to be a death sentence, or was considered to be a death sentence at the time. So what are the options? What are the options? And these options have not changed a lot over time. One is to move patients to supportive care and hospice therapy. The second is palliative surgery, i.e. connecting a distant loop of bowel with a proximal loop of bowel and hoping to bypass an obstruction. Cytoreduction surgery alone, i.e. doing these big operations, we used to call them multivisceral organ resections. Sounds sexy, huh? Multivisceral organ resection. And then cytoreductive surgery and intraperitoneal chemo, which we talked about, and then systemic chemo. We know that systemic chemo wasn't really effective because there's a plasma peritoneal partition in which chemotherapeutic agents very rarely move from the plasma into the peritoneum. And so if we think about colorectal cancer, which again has a very outsized effect on individuals in the state of Louisiana. In fact, 1 in 3 patients who are diagnosed with colorectal cancer in our state will either be stage 3 or stage 4 at diagnosis. 20 to 30% of all patients during the course of their disease will develop peritoneal carcinomatosis from colorectal cancer. And in fact, 10 to 15% of them will have peritoneal carcinomatosis at presentation. And if we look at the delivery of chemotherapy in patients with peritoneal carcinomatosis relative to patients who have lung disease, who have lung metastases or liver metastases, peritoneal carcinomatosis patients had worse outcomes. You attribute that to the fact that we've got a peritoneal plasma peritoneal partition that prevented the effective agent from reaching the tumor sites. And unfortunately, their clinical course is marked by bowel obstruction and palliative surgery. And this surgery, as we alluded to before, has a very high complication rate. And so I decided to really think about how we apply novel immunotherapeutic approaches to peritoneal disease. And this was the TEMPO trial. Now, the TEMPO trial was a trial in which we used previously an FDA-approved oncolytic virus in the peritoneum as a phase 1 trial to test the safety of this drug. And so we treated, I believe, 18 patients with stage 4 disease that could not be completely resected at the time of abdominal exploration. In other words, this was a population of patients who had very few therapeutic options at the time. We also treated patients with ovarian cancer as long as they were platinum resistant, and then they had radiographically measurable disease, i.e. we could follow them on CAT scans, or they had tumor markers that could be substituted for radiographic imaging to understand the efficacy. Okay. So it was what we call a 3x3 dose design, escalation design, which basically is you treat 3 patients with a certain dose. If they do okay, we treat another 3. If they do okay, we treat another 3. However, if one person in either of those cohorts had a side effect, we would expand it by another 3 to make sure that that toxicity was not what we call our dose limiting toxicity, i.e. the drug dosage that we would use moving forward in the clinical setting. And so these were the doses of viruses that we would give. And I'll suffice it to say that everyone got 4 × 10⁶ plaque-forming units injected into their abdomen through a port on treatment day number 1. And then they were subsequently 3 weeks later, they were subsequently treated with their treatment doses, which was either 4 × 10⁶ PFU, 4 × 10⁷, or 4 × 10⁸ plaque-forming units. And then after 3 weeks of this induction dose of chemo, so that we could form some type of protective antibodies within the peritoneum, they were treated with their cohort dose for every 2 weeks for up to 4 doses. Now, I'm happy to report that we recently completed this trial. And again, this trial was a multi-center phase 1 trial, which is really what you have to do in the setting of peritoneal disease, given the rarity of it, or rarity of patients who are able to withstand these trials, between Wake Forest, Duke, and the University of Illinois in Chicago. And we're actually actively looking at data and biologic endpoints in this patient population so that we can, number 1, evaluate our primary objective, which is see, is it safe? Okay, nobody got sick. Everybody did fine. Everybody just carried on as if nothing happened. Second part of it is what's the pharmacokinetic profile of the virus, which is our secondary objective in viral shedding after intraperitoneal hemorrhagic. And so we actually took samples from the peritoneum at given time intervals so that we could understand the survival of the virus in the peritoneum. We also collected saliva and blood on a regular basis, or saliva and urine on a regular basis to make sure that they weren't spilling virus into the environment or to their loved ones. And the exploratory objectives are we're looking to see the clinical activity of hemorrhagic with time to progression, overall survival, and patient-reported outcomes. Now, the thing that I think is pretty cool about this, and that really gets me going about clinical research, is that we collected samples so that we could look at changes in cytokines, changes in immune populations in the peritoneum of these patients after treatment with hemorrhagic. And so it's going to take us about a year grind to get those data together, but I think that we should have some extraordinarily fascinating data. So with respect to my work with hemorrhagic for the peritoneum, number one, it has been proven to be effective against melanoma. Secondly, again, we treated 18 patients in a phase 1 dose escalation trial and had no significant clinical toxicities. And we're looking to evaluate hemorrhagic-driven alterations in immune cell and cytokine composition, which could potentially be responsible for its therapeutic effects. And this is actually the basis of a brand new collaboration that I have with Gus, so that we can begin to at least model this in the murine model of peritoneal carcinomatosis. And in fact, it's so fresh, I'm taking the virus home as soon as I finish this talk. Well, not home, but to the lab as soon as I finish this talk. All right, so the thing that really got me into understanding oncolytic viral therapies in peritoneal carcinomatosis is the use of vesicular stomatitis virus, and a virus that we mutated in the lab, which would be a novel approach in addition to herpes simplex virus. So a funny story about VSV. VSV is the biology of VSV is very well known, okay? And in fact, I was giving a talk in about 2006 for a grant, which was a little scary because it was in the middle of this U-shaped table with people who had won Nobel laureate. It was just a hot mess. And so this guy stood up and, he asked some questions and it was fine. He stood up, he said, Dr. Stewart, that was a great talk, but I don't believe a word you said. Been working with VSV for 40 years and none of this jives with my experience. Okay. So fortunately, my dean told me to have extra slides at the back. And so we went at it for about 10 minutes and then I got to get out of their hot seat. So vesicular stomatitis virus, the wild type virus shown at the top, and the M51 mutated virus in which we have methionine or arginine substitution at the 51 position of the M protein. The wild type virus will never be used in the clinical setting, okay? It shuts down host cell transcription, it shuts down host cell viruses, and patients, or mice rather, get pretty significant encephalopathy after treatment with recombinant wild type VSV. However, in the mutated VSV, it does not shut off host gene transcription and it induces host antiviral responses in normal cells. Okay, so it's therefore potentially a very attractive oncolytic agent. And we've looked at this in a number of histologies for a number of years. And shown here is just a sample of the publications that my lab has produced based upon oncolytic or based upon vesicular stomatitis virus. So we created a murine model of peritoneal carcinomatosis. Shown here on the left, on the right is the human condition of carcinomatosis. Another picture. And you guys are like, I'm sick of you showing us these gross pictures, but hey, that's what I do. And to the left is the mouse condition, in which we inject CT26 colorectal cancer cells into biopsy mice to produce carcinomatosis. And over the first couple of years of my lab experience, we had two study aims. And so the first aim was to evaluate the oncolytic potential of vesicular stomatitis virus in peritoneal surface malignancies. So shown here are the data that were published by by Glenn Day, a wonderful medical student that I had at Wake Forest several years ago, who's now a pulmonary critical care fellow. I could not convince her to go into surgery. What's shown here is mice that we injected with CT26 cells, and then we divided them to treatment with M51R virus, a single dose of M51R virus, or a single injection of mock treatment, which was PBS. And then we followed these mice for 16 days. And what we saw is that the mice that were treated with M51R vesicular stomatitis virus had significantly reduced viral growth relative to mice that were treated with mock injection. So shown here are five representative mice of 10 from who had luciferase reporter injected into their abdomens, and then had bioluminescence studies done. And we saw that at the top, we had significant bioluminescence, i.e. suggesting significant tumor burden relative to mice, and in which 4 or 5 did not have any bioluminescence activity. You know, clinicians also care about survival, right? How long does the patient live? All right, so shown here is our experiment, which we followed the mice out to 60 days, and you'll see that the median survival of mice that were treated with PBS was 22 days. The median survival for treated mice had a median survival of 22 days, and M51R mice did not have a median survival recorded. So in other words, there was a significant difference in overall survival associated with M51 treatment. And so the second study aim was to delineate the immune mediators of oncolytic viral therapy for peritoneal surface to lymph dissemination. And so what we did here is that we established the CT26 tumor cells, and then we injected these, injected with our M51R virus or our PBS virus, and then we took peritoneal supernatants at days 1, 3, and 7. And so days 1, 3, and 7, we wanted to look at the cytokine profiles, but we also wanted to immunotype the peritoneal exudate stage cells. And back then we used 8-color flow cytometry. And, you know, I got to tell you, when I got to Duke, they were talking about Tesla for the magnets on their flow cytometer. So that was a wake-up call to me. So shown here are the data around the immunophenotyping. And so I'll draw your attention to these 5 important panels. So the very top panel shows that we have a statistically significant higher frequency of CD4 positive T cells. Here we had an increase of CD11B cells, and those were myeloid lineages. And then we looked and we saw that there were the higher frequency of macrophages and a lower frequency of myeloid-derived suppressor cells, which suggests that this virus actually decreases anti-tumor immunity, which is not unexpected because once you get a viral infection, your body's goal is to get rid of that viral infection. And decreasing the brakes of the immune system, i.e. myeloid-derived suppressor cells, is one way to do it. Secondly, we saw that we had an increase in B1B cells. Anybody familiar with peritoneal B1B cells? Yeah, so let me just run it by you real quick. And the reason I'm interested in is because Kate Haas, who was down the hall, her lab was down the hall from me at Wake Forest, is a B1B expert. So this is actually a B cell that has antigen presenting functions found primarily in the peritoneum rather. So we looked at the cytokines and we had 2 interesting findings. Both MCP1 and IL-6, which were immunosuppressive cytokines, were downregulated with M51R VSV infection. And again, that is of no surprise if we think about the fact that the body's natural response is to increase its immunity against VSV. So I show this, and it's a busy slide, and I apologize, but this is actually a nice collaboration that I had with Dr. Brodsky from Pine Bioinformatics here on the LSU campus. And so just in summary, we took the T cells, we cloned the T cell receptors, and then once we cloned the T cell receptors, we began to understand which peptides or which groups of peptides these T cell receptors were reactive to. In other words, what's the epitope that these T cell receptors are responsive to? And what we found is that We had high clonal fractions, and primarily about 4 of about 5 sequences. And then what you'll note is that murine leukemia virus was represented here. And this actually was further linked to AH1, which is a tumor-associated antigen for colorectal cancer. Okay. And so it suggests that treatment with a single dose of M51R virus can increase tumor-specific anti-tumor immunity. And this has not been reported previously, and we're writing this up at present. So in conclusion, one can see that regional treatment with VSV can serve as a novel treatment against peritoneal carcinomatosis, and that M51R VSV actually drives immunity and cytotoxic composition in the immune microenvironment to have a therapeutic effect. And finally, there's a coordination that we believe happens between the innate and adaptive immune system that can further drive responses. So what's the future work? Where are you going with this? So number one, as mentioned, we've just finished our phase 1 trial. We have to think about how we move to larger trials, potentially your 1A, phase 1A trial / phase 2, looking at combination therapy. In other words, can we add immune checkpoint inhibitors in the peritoneum to improve response? Can we design viruses that downregulate things like LAG3 and other immune checkpoint inhibitors to drive therapeutic response? Secondly, we need to understand how we identify predictive markers for response to VSV, because we know not all tumors are responsive. And in fact, in my original work back in 2011, we saw that only 2 of 3 cell lines that we looked at were sensitive. And so how do we take those human samples? How do we create organoids and other important approaches to treat with VSV and determine which ones are sensitive and which ones are not, therefore leading us to a personalized oncoimmunotherapy approach. And then finally, delineating combination therapies in future clinical trials to improve outcomes. So I'd like to acknowledge people who have been along this journey with me for the past almost 20 years. Doug Lyle's lab at Wake, the Wake Forest HIPEC, which is heated intraperitoneal chemotherapy group, Ed Levine, Perry Shin, now Kostas Vodnopoulos, and Kostas has carried this work on a little bit by designing immunocompetent organoids. Duke University, my clinical partner, Trey Glazer, John Strickland is a medical oncologist, and Kent Weinhold, who actually runs the flow cytometry core there. And then my current lab at LSU, which includes Vijay Kumar and Caitlin Bauer. So with that, thank you, and I'd open the floor for questions.
And I could start with one that everybody warmed up here. So done great presentations. Wonderful to see actually a physician and surgeon be interested in these molecular technologies and how they could be applied to those. So the issue is obviously using colorectal tumor cells in this mouse system, but you did distinguish peritoneal, intraperitoneal cancer from colorectal cancer. So to what extent are those similar or different?
Yeah, so that's a great question. And honestly, I think it sets us up to do something unique. And so the things that we discussed were actually peritoneal metastasis from colorectal cancer. So usually if you develop metastatic disease from colorectal cancer, the majority of it is in the liver just because of portal circulation from the colon, and some of it is in the peritoneum, which they think is related to mechanical breakdown of the tumor and subsequently binding to the peritoneum. But the immune microenvironment of the peritoneum is different from that of the liver, and it's different from that of the lung. And so we think that having a model of the peritoneum allows us to ask questions, not only the peritoneum, but subsequently to compare responses between the 2 metastatic sites.
I guess a follow-up question to this, and then we'll go to the audience. Wouldn't you think that the TVEC in Ligic would GMC as set, based on the fact that perhaps you're relying on better antigen presentation intraperitoneally would probably do better than VSV?
Yeah, so great question, a tough question, because I kind of hold that VSV close to my heart. But we don't know, right? We don't know. That's why, we're working together to try to figure out similarities and differences in response between VSV and HSV. similarities and responses between the human model, or patients, and the mouse models. And so it's hard to know. I think that we're beginning to try to understand things such as CGAS and STING activation and things that that we're beginning to understand. And it's clear that there will probably be differences in modulation just based upon the biology of those viruses. But yeah, that's a great question, and it really keeps us up at night, right?
It means to be explored.
Yeah.
So we had a question with it.
I enjoyed the history part of this talk.
Yes.
Is the Onyx story over?
It's over. It's over. I mean, I couldn't even tell you where to get the Onyx adenovirus. I'm sure it's out there somewhere, but nobody's picking it up and running because now we have an FDA-approved virus. I think that the polio virus from Duke is probably going to get approved at some point.
And Dr. Wang.
I really enjoy your talk, but I also had a discussion for a very long time. So feedback from melanoma, I understand that you could be done by injecting into the tumor, but given the diffuse property of peritoneal tumors in the case study that you showed, I was wondering how the oncolytic virus can be delivered to the patient. And then what's the molecular basis of the property delivery?
So the way that we delivered it in our phase 1 trial is that patients actually had what we call ports, which is like a little hub where you could stick a needle in, and then it has tubing under it to just drive the virus into the abdomen. And then we had the patients turn on their side for 30 minutes, turn on the other side for 30 minutes, sit up for 30 minutes, so that we got tumor spread throughout the abdomen. The basis for this, as we mentioned before, is the fact that cancer cells have defective antiviral signaling, right? And normal cells have effective antiviral signaling. And so oncolytic viruses are selective for these cancer cells because the cancer cells can't fight them, right? So the viruses continue to replicate in these sensitive cells, just again, based upon molecular carcinogenesis that gives these cancer cells a proliferative advantage at the expense of antiviral signaling.
So thinking about the scientific testing, which would be the barrier to the next steps. So do you have any signaling pathways that you would think you need to focus on?
Yeah. So we're studying that, right? So initially we think about immune checkpoint inhibitors, and data that I did not show from our most recent work is that we have upregulation of LAGE3. PD-1 comes in a little later, which is, again, an exhaustion marker. But we also saw that we had downregulation of our myeloid-derived suppressor cells, right? And so MDSCs have been shown to inhibit immune responses for a number of tumors. And actually, if that's a mechanism itself that can help us improve anti-tumor immunity and drive a hot immune response to those tumors, those are very interesting pathways to pursue. I think that also we're beginning to more better defined pathways that determine responses to danger signals. And, viruses they're big danger signals, right? They're big danger signals. And so what we're beginning to see are things like in colorectal cancer, which the majority of these cancers have mutated P53. You inhibit STING, mutated P53 inhibits CGAS and STING, which subsequently, has downstream effects with respect to interferon regulated genes and interferon stimulated genes, type 1 responses. And so again, there are a variety of things that we can look at. And again, I'm excited to get to clinical trials because we can begin to look at them in humans as opposed to mice all the time. Very welcome.
I got Caroline Clark there, a graduate student from my lab and an expert on GM-CSF. So,
Outstanding. Hold on, when do you graduate? In May. Okay, we should talk. Unless Gus wants to hire you. Yes. No, in the VSV, yes. Yeah, we're still running the flow on those samples. So I've got nothing for you right now. That's a great question, right? That's a great question for us to try to get to, at least preliminarily, and then look at targeted responses in our next trial.
So John, I want to ask you a question beyond your science as
Mhm.
reported today. Obviously, you are the director of the Cancer Center, the appointed by President Tate to lead the NCI effort. Can you give us an update of where are we
Sure,
and how
sure.
you're proceeding on that?
Sure. So I was recruited, I think it was 2020, which is when things started, to come down to be the director of the Cancer Center. I think that there are a couple of relevant points that we need to start with. So number one is that there's no NCI designated cancer center in Louisiana, Mississippi, or Arkansas. 3 states with the highest cancer incidence and mortality in the country. Secondly, I'm from Louisiana, again, Shreveport. Some of you don't claim us, but yes, we are Louisiana.
Is Shreveport, Louisiana?
Yeah, it is. It is Louisiana. So, I left 30 years ago to do what I was going to do, and was happy to come back to lead that effort. And interestingly, Dr. Bill Tate became president around the time that I came in, and Dr. Tate was extraordinarily excited about it. And at his most recent Regents meeting, and I can say this because it's publicly recorded on YouTube, he says, if I don't do anything else as president of LSU, it will be to get us NCI designation. It's pretty significant. It's pretty significant. And, I've been fortunate for him to continue to pour resources into the Cancer Center. We're recruiting at a pretty hot and heavy pace. We've been able to recruit some clinician scientists, individuals who will write clinical trials, individuals who would conduct clinical trials. And we've had the fortune to recruit 1 basic scientist, and we've got 3 basic science teams that we're looking to recruit to bring into LSU. So let's think about some of the unique things that we're able to approach as a system, right? So we've got LSU Health Sciences Center in New Orleans. We have the LSU A&M campus. We have Pennington Biomedical Research Center. Now, health sciences has dental school, nursing school, school of public health. So there are all kinds of things that come together with that relationship that are extremely unique. But one of the things that I am most excited about right now, and hopefully I'll move on to get excited about something else in 3 months, is our ability to have community-informed research, right? And so for so long, we've sat in ivory towers and said, oh yeah, we think we need to do this type of research in the community. And the community doesn't care, right? They don't care about what we're trying to push down their throats. What is important to me is that we partner with the community so that they can inform our scientific policies, our research programs, so that we can advocate for making our communities better. Now, one thing that I heard loud and clear when I first got here, and it honestly never dawned on me, was that Louisiana is the 4th highest per capita rate of HIV infection in the country. Baton Rouge is number 2, metropolitan area. New Orleans is number 5, metropolitan area. And we have malignancies that are associated with HIV like nobody's business, okay? And the use of highly active retroviral therapy has not reduced our incidence of those cancers. And so we're actually growing a viral malignancy program. We just immediately before my arrival recruited a team from the University of Nebraska, world-class scientists who work throughout the world in viral-related malignancies, including working in HPV and HIV. But now we're beginning to recruit clinicians from around the country to come in to build that team. Again, that's community responsive research. What is it that we have in our population that needs to be addressed that can't really be addressed anywhere else? And then the other part of our research is that I have a very unique lens on cancer. I think most of us have had family members that have died of cancer, but when I look at the impact of cancer on underserved communities, it's something that drives me, right? And so our cancer center is squarely focused on understanding the health disparities that occur in our state And so working with groups such as Xavier to try to understand those issues, you know, and their trials like the TMS trials for breast cancer, imaging, in which we're actively working to address those disparities is again, something that I'm really excited about and something that the community has wrapped their arms around. One last thing is that the NCI is really excited about it. We do know for a fact that a school has to be the lead, and President Tate has fortunately given us that lead. And I look forward to the partnerships that we get to have to bring this to our state in the next 5 to 6 years.
Thank you, John. Thank you. Thanks, everybody. We're going into